My name is Raphael Bostic. I'm a professor in the Price School, and I am the director of the Bedrosian Center in Public Enterprise. I'd like to welcome you to the latest in the Quintiles lecture, which is not my lecture series, but I'm going to introduce you anyway. I just wanted to say, for the Bedrosian Center, I don't know if many of you have been to our events, but we're a center that focuses on governance, and we are really concerned about issues of implementing policy. So what are the challenges of doing policy once you know what it is you want to do? And as part of our programs, we've tried to, we have a real interest in partnering up with all of the disciplinary fields where there's a lot of expertise on how do you design policy to marry the two together. So you have to design and you have to figure out how to implement it. And we want to make sure that people think about those governance challenges as they design a policy and as they try to do it moving forward. This is one of the reasons why we're really pleased to have Dr. Katz, because he's now been doing the implementing of public health policy in two different places that are very different. And from our perspective, it's really interesting. I'm really interested to hear the challenges and the comparative approach to that, as well as all the stuff that's changed in health policy. So that's all I'm going to say. I'm going to turn the floor over to John Romley, who will introduce our guests. But thank you all for coming. It's really good to see such a nice turnout.
Thanks, Raphael. So just by way of a little background, in case you're not familiar, I think probably many of you, maybe most of you are, but Dr. Katz has quite an interesting background. Trained at Harvard, was the chief of HIV research in San Francisco, went on to head up the Healthy San Francisco initiative that brought universal health care to that location. Has been down at heading up the LA County Department of Health Services for a while now. And we're just thrilled to have you here. We're glad we finally made it all work. And I'm not just saying that because look at you wouldn't know what the counterfactual is, but this is wonderful attendance.
I'm really happy to see all of you and talk to you about making a difference. I'm a big believer that in whatever you do, there's a tremendous opportunity to make a difference. And what I want to use the time that we have together is to talk about a set of challenges that I faced along the way on where, as Raphael was talking, it was clear what the policy goal was. The challenge was, how are you going to do it? And that's pretty much how I would frame any problem. Once you figure out what it is you want to do, right? So what is the good thing? What is it you're going to achieve? Then you just have to figure out, well, how are you going to do it? And whatever the obstacles are, you have to figure out the plan over the obstacles or through the obstacles or under the obstacles, but that you always keep the goal in mind. So this for me was, the needle exchange in San Francisco was the single defining event of how, my career was set, because it set a tone that I've used throughout my career. So worst years of the epidemic, epicenter of San Francisco, highest per capita infection rate, highest rate of death. AIDS becomes the #1 cause of death in men. It's like an unbelievable thing, right, overnight, right? No longer heart disease, not cancer, but AIDS, right? Very poor treatments. Prevention, somewhat effective when you can get people to practice safer sex, use condoms, but huge problems with needle users, right? So people exchange needles, then they become infected. Huge problem, especially because people were using needles, then they were infecting their sexual partners, so people who were not using needles were getting infected. Babies were being born with HIV infection. And we had a common sense prevention, which was clean needles. And in fact, at the time, there was quite clear evidence that in those places, like mostly West European cities at that time, that had needle exchange programs, infection rates were very low. And in places like New York City, Newark, Miami, where there were no needle exchange programs, infection rates were very high. The challenge for me was, we had in San Francisco one of the early renegade needle exchange programs. It's grassroots, which is often the best way that anything happens. People come together, distribute needles. But the problem was that the demand for the program was so great that they couldn't fund the needles anymore. There's just too many people wanting clean needles. And because California law said that syringes can only be dispensed with a doctor's prescription, there wasn't any public funding possible for needle exchange because obviously needle exchange didn't operate with prescriptions. And it wasn't even possible for them to fund themselves as philanthropic money, donations. I mean, well, people could donate, but it couldn't be tax deductible because it's an illegal activity. So I had a huge problem raising money for needles. So what do? Okay. You ask yourself, okay, so needle exchange is technically speaking illegal. Is there any countervailing law that you can find that might help you to make needle exchange happen, right? That is to say, if one law says you can't do this, but another law says you must do this, then sometimes you can make something happen. And so what we discovered, looking very hard, we couldn't get around the fact that it took a prescription to dispense needles, but state law allows counties to suspend laws in cases of public health emergencies. Public health emergency. Well, this is a public health emergency, right? AIDS is now the #1 killer among men in the city. It's an infectious disease. I have a method of preventing it. Let's declare a health emergency. The board declared a public health emergency. The mayor signed the bill, even though the county council at the time advised him that A, he could get arrested, and B, what's even worse for a politician is he could be barred from running for any future office. But nonetheless, we had a huge grassroots support for this, and he signed the bill. Needle exchange was funded. Just to show how ludicrous this was, we had to renew the public health emergency every 2 weeks for 9 years. So I ask you, what kind of public health emergency could exist for 9 years continuously, right? At some point, clearly it's not an emergency. It might be a huge problem, but it's hard to argue that you could have an emergency for 9 years. But it provided the roost, the frame, whatever you want to think about it, the countervailing law that allowed 2 million needles to be exchanged, dirty needles, for 2 million clean needles. It not only prevented HIV, but hepatitis B, and now we would recognize also hepatitis C. At the time, hepatitis C wasn't even yet defined. It was just called non-A, non-B hepatitis, and the tremendous death rate due to hepatitis C wasn't appreciated. So we did a lot of good. In 1999, now remember I did that in 1992. 1999, the state passed a law allowing counties to establish a needle exchange programs, but only if they declared it an emergency. So they actually stole our line, right? So they couldn't get themselves in 1999 to say, okay, you can use public money for needles. But they got as far as saying, okay, well, if you're a county and you declare in an emergency. So now we had, I think it was 4 other counties every 2 weeks declaring a public health emergency year by year by year. 2011, California passed the law that allowed needle exchange programs to be funded without an emergency order. And lest you think that this is some, prehistoric story that has no relevance, you cannot fund today needle exchange with a federal dollar. Federal dollars for HIV prevention cannot be used for needle exchange, even though needle exchange is a known effective HIV prevention strategy. They briefly allowed funding in 2009 So that would be 17 years after we did needle exchange, but Congress reinstituted the ban in 2011. So meanwhile, San Francisco continues to exchange needles, and we not only saved lives by doing that, but we taught California how to do it in other counties. I now use that, and I mean, one of the funny ways that my San Francisco experience has helped me throughout my career is, so someone comes and tells you that something's illegal, I'm like, okay, how else could we do it, right? I'm not interested. I mean, I understand that, you know, you can't do things just that are illegal without coming up with at least another law or a way around it. But I'm not moved just because you tell me that something good is illegal. I'm not going to just back off. So here are some other examples of how you might look for another way to do it. So let's move a little bit from an HIV to a sexually transmitted disease clinic and tell you about a pressing problem we had, which is that women would come in for STD diagnosis and treatment, and they would have tremendous trouble getting their partners to come in. The male partners were very reluctant to come in. And so what would happen to the women is they'd get reinfected, right? So you would treat them for the infection, but if the partner doesn't get treated, right, then they're going to keep getting reinfected. What had been done unofficially is in many private gynecologists' office, a gynecologist would just give a woman a prescription for her partner. And of course, this can go the other way. You could have a male partner whose woman partner wouldn't come in. It goes either way, but epidemiologically, it was mostly the women partners who couldn't get their male partners to come in. But technically speaking, the California Medical Practices Act forbids the prescription of antibiotics by a physician without examining the patient. So while a gynecologist could do that on their own, I'm running a large county system. I can't actually, without coming up with something else, I can't just send a letter to all my doctors saying, please act counter to the California Medical Practices Act. And I want you, for the good of these women, I want you to send home a prescription for their partners. I can't do that, right? I can't just by saying, you know, I want you to do this for that to happen. But okay, so let's go for do we have a countervailing rule? So Health and Safety Code also authorizes the local health officer to take all necessary measures to prevent the transmission of infectious diseases. Oh, well, this is an infectious disease, and I could prevent the transmission of those infectious diseases, so maybe I do have a way of having my providers do this. So I changed the policy. I wrote a letter to all my clinicians, so just go back and said, California Health and Safety Code authorizes the county local health officer, blah, blah, to take all necessary measures. As your local county health officer, I am authorizing you to send home prescriptions for men and women to give to their partners to take. And the physicians then felt comfortable. Well, after all, their director had done it. Go ahead.
What fraction of physicians do you think read those?
They almost, well, I wrote the memo so that nobody would feel that they were taking on the limb. I actually talked with all the people. The STD Clinic is, so this is specific to the county clinic, right? I didn't try to organize all of the doctors, because you're right, that would have been a very different thing. I'm in a small clinic, but it's a categorical clinic and is doing almost all the STD care, or a lot of it in the county. So because I'm always interested in not just how you fix something, but how you fix it in a way that makes everybody's lives better, not just the people you directly touch, I wanted to have some data. Now this gets into an interesting question where I often argue with academics about the question of data. So there is the data that's necessary for you to feel that drug A is better than drug B. And that's, needs to be really rigorous data because it's easy to confuse the effects of drugs, and drugs can have side effects. The level of data that I need in order to make policy change is very different. The people I'm working with are not reading the New England Journal of Medicine. They're not asking whether or not in the randomized trial everybody was blinded to their drug assignment. The world doesn't work that way. Most of the things I do are not subject to randomization. But what policymakers do look for is what's the evidence? Show me the evidence. But they don't always have the same ideas of what evidence might be. And so the argument that sometimes comes with researchers has to do with rigor, right? They say, but isn't it important to have the most rigorous design possible? And I say, isn't what matters whether or not you get the policy change that you want the policy change? So in this case, here is an incredibly weak study. We surveyed STD clinics who received partner packets. And 73% of the patients, 73% of the patients said that their partners took treatment. And we said, gee, that's a lot higher than our experiences. And the 57% then discussed STDs. And we said, that's not what we think generally happens. And that was our only quote-unquote evidence of the success of our practice. On the basis of that, and on the theory, I got the San Francisco Medical Society to vote to support partner treatment. And the reason I asked them, which again is here, one of the little secrets is coalition building. How do you build coalitions? Well, the first thing you do is you go to who's the easiest group to get, right? You don't start, if you have an initiative like this, I wouldn't start with the American AMA, which is a very conservative private doctor group. I started with the San Francisco Medical Society, which of course I'm a member of, and has more of the values of San Francisco. They supported the partner treatment. And then the California Medical Association, which is somewhere on the spectrum sort of between the San Francisco Medical Society and the American Medical Association, I knew that if I just brought to them the idea, they would say no. But if I brought them the idea as passed by their affiliate, the San Francisco Medical Society, they would be inclined to do it because their whole structure is about affiliates. So all the affiliates come to the state meeting, just like then all the states go to the national meeting. So they approved it by only one vote, with a lot of concerns being raised about, well, how do we know what's going to happen, and what if someone gets an adverse reaction, and all the perfectly reasonable things, but things that are not as important as whether or not the partner gets treated for the STD. So it won by only one vote. But of course that doesn't matter, right? When you're getting endorsements, you just need an endorsement. Nobody knows when you go to lobby, as we did when we had this Senate Bill 648, 2001, I got to put all over it that it was endorsed by the California Medical Association. I didn't have to say, parentheses, you should know that I only won that by one vote, and that was only because I did it through the affiliate of San Francisco. Right? I just said California Medical Association supports this. Even so, I only got chlamydia. The state legislators redlined out gonorrhea. They did not authorize the prescription of medicines for gonorrhea. Legislators don't like to talk about gonorrhea. Gonorrhea has a different socioeconomic status, epidemiology, than chlamydia. Chlamydia is more of a middle-class disease. People understood chlamydia. They understood the possibility that their children or grandchildren might get chlamydia, their daughters, their granddaughters be infertile, not produce grandchildren. People understood chlamydia. People were reluctant to pass a bill about gonorrhea. So it got redlined out. Did I say when they redlined out, did I go and march and say, this is terrible, I won't accept this bill, if you don't put back gonorrhea? No. I said, thank you very much, because what I thought is, I'll come back at them, right? If this is what they're comfortable with, I was still doing what we were doing based on our local, let me get the bill I can get. And then 5 years later, we got Assembly Bill 2280, which authorized patient-delivered therapy to partners with gonorrhea or other STDs. So we got it broadened 5 years later. I had to wait a little bit, but it happened. And this remains, of course, the law in California. And then some time later, 2005, a study comes out, still not exactly the question, because this was expedited treatment versus standard treatment. But it showed that when you gave people expedited treatment, the chance of recurrence of an STD was lower. So basically we ultimately proved the point. But as has happened a lot of times in my career, the proof that it worked occurred after I got the change, not necessarily before I got the change. HIV testing. There remain in this country substantial numbers of people who are infected but don't know they're infected. There are lots of barriers to testing. People are in denial, people are frightened, people don't know they're at risk. Lots of barriers that are hard to change, but change the ones you can. So one of the ones that I had thought a lot about as a clinician was the written consent for HIV testing. So at the time, the standard, and this is in the 2000s, was if you're going to get an HIV test, you had to do a written consent. And the reason that this discouraged people from testing, and I don't know how many of you have ever been in a hospital, been with someone in a hospital or an exam room, doctors are not necessarily great communicators, right? And often they say, please go for these lab tests. And people don't know what lab tests they're actually getting. They're often frightened at how many tubes of blood are removed from them. But if you imagine under that paradigm, and then somebody says to you, I want to do a blood test, but before I can do this blood test, I need you to sign a consent, right? You're in a hospital, maybe someone's trying to diagnose a condition that's so far been undiagnosed. You're a member of a disenfranchised community. You're gay, you're an injection drug user, you're African American, you're Latino. Nobody seems to know what's wrong with you. They've been doing all of these tests, and no one has asked your permission. And all of a sudden, someone comes into the room and says, before I do this test, I need you to sign this form. Wouldn't you be suspicious about why it is that they've just been drawing all this blood from you without any consent, and all of a sudden, someone is showing you a consent? I think I would under those circumstances. I think I would ask myself, maybe there's a reason that they have a consent attached to this, and maybe I don't want this particular test. Not to mention that hospitals being what hospitals are, half the time the test wasn't done because the resident in the hospital forgot that the form had to be signed, and the blood was drawn, but it went to the lab without the form, and the specimen got thrown out, and meanwhile the person was discharged, and all the other things. So I started looking at this written consent issue, and I discovered, and I have to say I was surprised as someone who had grown up in the era, that there was nothing in the law requiring a written consent. What the law said was that people had to be consented in order to get HIV tests. A very sensible requirement, especially in the era when the test could result in you being discriminated against for insurance, and there was no obvious benefit necessarily of knowing because there wasn't very good treatment at this time. So when that original law was passed, that made sense. It were the hospital lawyers who added the written consent. The law didn't say written consent, but the hospital lawyers, when they read this, immediately, right, lawyers are always risk averse. I don't know how many of you are or want to be lawyers, but lawyers tend to be risk averse, right? Their job, if you're a hospital lawyer, your job is not the same as my job, even though we might both work for the hospital. My job is to promote health, right? So if somebody is HIV positive and I need them to know in an era, because by now great treatment is available, the ability to prevent transmission to the fetus is available, right? It makes a big difference by this time when I'm working on the issue. So I really want to know. Hospital lawyers, their job is to protect the hospital and the doctors from being sued. So they had put in the written consent because their question was, well, how would we know if the patient consented unless the patient signed the form? So we said, well, now that we see that, we're going to abolish the written consent form, and clinicians need to note in the chart that they consented the patient, as you should do for any test. So clinicians consented the patients. We eliminated the written form, and in a time series, the latter part is what happened. All of a sudden, the elimination of a simple form resulted in more people getting tested, and although I didn't bring the data, it wasn't just healthy negatives. There were more new positives found. So that simple change, and then, okay, so with that experience and the same idea that you want to make change and make things better, not just for the people you serve, but for everyone, we changed the standard to right to decline. So the people now, the modern standard, which fits the risks and benefits of the test, which are very different than the risks and benefits when the test was first created, now say that as a provider, when I test someone, what I say is, and I'd like to test you for HIV because you've had sexual risks and this could explain the symptoms you have. Is that okay with you? And they have the right to say, no, I don't want to be tested for HIV, in which case I wouldn't do the test. But it's no longer a can I consent you. It's more in keeping now with how I would introduce other tests. So that is the law for HIV. Tobacco, number one cause of preventable death still. San Francisco became the first locality that banned pharmacies from selling tobacco. I felt, to me, this was a personal issue that came up in part because my daughter has asthma. And so I was going to our local pharmacy, and I'm just sort of standing there, and I'm about to pay for her asthma inhaler, and I'm staring at a wall of cigarettes. I'm thinking, God, that seems really wrong. Have this big sign, about, Walgreens is your health provider. I'm like, well, if you're my health provider, what are you doing selling the tobacco? And what about the conflict of interest here? The more tobacco you sell, the more of these inhalers you're going to sell. That doesn't seem quite right. And what would be the message if you believe, and as I do, that social messages matter, right? You're a 19-year-old. You walk in under the sign that says Walgreens cares about your health, and there's all the tobacco, right? What kind of message does that send? So I guess I didn't bring the who else did it. So after we did it, Boston did it. Several counties in Massachusetts did it. Another city in California did it. And then CVS agreed to stop selling it. And we're still working on some of the other big providers.
Curiosity, what fraction of cigarette sales are at pharmacies prior to this?
In San Francisco, I'm trying to think if we were not ever able to figure that out because it's retail data and no one wanted to give us retail data. What I did check, because the pharmacies complained that it was unfair to them, I checked that after a few years after the ban, there were actually more commercial pharmacies in San Francisco than before the ban. So it could not have been so important to their economic bottom line. They survived. Healthcare coverage, we're at 2008. I'm in San Francisco. Clinton's bill had failed. Got Governor Schwarzenegger came within one vote of passing for California a health reform that was very similar to what had been done in Massachusetts, employer-based. And we're like, okay, San Francisco, has always been on the forefront. We want to have universal health care coverage. So we created Healthy San Francisco, which is the only still coverage initiative that provides health services to the uninsured regardless of income, immigration, or pre-existing conditions. I'll come back and talk about it. I now have a program in Los Angeles that is regardless of immigration or pre-existing conditions, but only takes care of the lowest income people. San Francisco's was truly everybody welcome, people pay based on their income, but was not limited to low income people. It provided a standard benefit package even though it was not insurance. It was coverage with services provided by a network of providers in San Francisco. Worked very well. We found an independent group did a satisfaction survey, found 94% of enrollees were satisfied, 92 recommends a friend, and 41% reported that their health needs were better met than before the program, even though people were generally going to the same providers they were going before, because all it was knitting together the existing providers in San Francisco, all of whom had their own individual program, and we turned it into a comprehensive program by putting together the outpatient clinic, the hospital, the pharmacy, and sort of branding it and giving people a card and helping people understand what the costs were. But generally, they were going to the same places they were going before, and yet they were more satisfied. They were more likely with Healthy San Francisco to have a usual source of care. They were more likely to use outpatients than the uninsured group were. We found less inappropriate emergency department use. It was copied by Howard County. Obama, in the midst of the the debate for Obamacare, shouted out to Mayor Newsom, if San Francisco could do health reform, surely the nation could do it. So the one problem, which I'm telling you at the end, but I was told at the beginning, was it's illegal. You'll never get this through court. The smartest lawyers said, ultimately, the model of Healthy San Francisco, which persists today, could never survive a court challenge. And you will be sued and you will lose. What were they talking about? Well, without getting into, I want to give you just enough so you can understand, because it is a fascinating story about how you get stuff done, even in the face of things being quote unquote illegal. So there was a law passed in the 30s called ERISA. ERISA was a law that was really not targeted about health care. It was a law, the country is growing at this time, and you're getting all of these multi-state companies, the forerunners of groups like McDonald's or Target or Walmart. And sensibly, these companies, they don't want to have to deal with every tiny county, city's requirements of what their employee benefit packages should be. Right, so that makes sense, right? You want to spread. You don't want companies to have to deal with, this one says the deductible can't be more than $200. This one says the deductible can be $300, but the co-pay can't be more than $5. You'd go crazy. So they passed this law that basically said that you could not impose benefit requirements on businesses. And so this is what made it really hard to do any kind of local program, because if you wanted something employer-based, it wasn't clear if you were not, at the state level, how you were going to do it. We got challenged by the Restaurant Association. Why the Restaurant Association? Because they had the largest concentration of workers that were uninsured of any businesses, right? That's historic. Retail, your average Macy's worker is insured, your average waiter, this is previous to Obamacare, uninsured. So they just had a lot of people to do it. So we prevailed in the Ninth Circuit, which is a very liberal court, but we prevailed again, not just because it was a liberal court, but because we had created a reason for them to exempt us. The Healthy San Francisco was not an insurance product, specifically so we could argue that, well, since we're not an insurance product, we're clearly not covered by ERISA. ERISA is not an ERISA health plan. It's not a health plan that is registered as an ERISA product. And that would work in a court that was, on the liberal side of these kinds of issues. We knew if we got to the Supreme Court, we would lose. So if you know that, then what do you have to do? You have to convince the Supreme Court not to take the case, right? You know what's going to happen if they take the case. But can you convince them, remembering that courts, right, up into the Supreme Court, they have to hear it. Supreme Court does not have to hear a case. So we prevailed on them. We got, for one thing, we got the Obama's labor secretary to put in an opinion that it was not conflictual. And then we wrote a brief that was all about why they shouldn't take the case, citing the fact that this was a small county, that health reform was going forward in the country as a whole, which would make this small program irrelevant, and that there was no need for them to take the case. And they never took the case, and Healthy San Francisco proceeds. So just because well, first it illustrates, and I didn't put, the first court that heard it before the Court of Appeals, the district court, voted it out. We appealed then to the Court of Appeals, and they were the ones who said we could keep going. So that's another general point about these things, is when a lawyer tells you passionately that this is not legal, you have to remember that nobody really knows what's legal in most cases of these kinds of issues. I mean, we know murder is illegal, but one court said it was illegal, and the next court said it was legal, and if the Supreme Court had heard it, they would have said it was illegal, right? I mean, they're all looking at the same laws, right? They're all inferring what a congressional ERISA law passed in the 30s means about a universal health coverage product that is not insurance in San Francisco means in 2008, right? And so there's room for disagreement.
Is there any debate on whether that universal health coverage was actually a health plan?
No, truly, no. Well, not at the Ninth Circuit bought that it was not, but actually I think that the district court said sort of looks like a duck, quacks like a duck.
Yeah.
Right, well, that's the argument.
But what's your definition of that, why it's not?
So our reason for why it was not an insurance plan was that it was it had no coverage outside of San Francisco. So unlike most plans, right, where you have coverage, right, if you travel, this was truly a local plan. It was unregulated by the state. So those were, we also, I didn't want to spend too much on the details, although they're fascinating. The actual law that was challenged was not Healthy San Francisco, because Healthy San Francisco was a feature of the law. The law was an employer spending mandate. It said that every employer in the city and county of San Francisco had to spend a certain amount per employee work hour on health benefits. And they could spend that money by setting up a health savings account, by paying bills however they wanted, by buying an ERISA insurance plan, or by contributing to healthy San Francisco. And so we argued, you see, that we're not dictating anything. It's nothing about benefit packages. All the city and county is saying is that each business must spend this amount of money. But district court said, looks like a duck, quacks like a duck, as best as I remember. Okay, so coming into today's time, so Los Angeles, second largest safety net system in the country, 4 hospitals, 2 former hospitals, 15 large community centers, many small clinics, 700,000 unduplicated clients a year. So I came at 2011, which is sort of the dawning of health reform, which, the Medicaid expansion went into effect 1 year ago. And the problem is that expansions have historically been disastrous for LA in the public sector. So when Medicare was promulgated in the 60s, all the seniors left. They just left. They got better. They had other options. We're out of here, right? We're not at LAC. We're not at Harbor. We're out of here. We're going to private hospitals.
That just speaks to quality, right?
Absolutely. Medicaid, same thing. Pregnant women get Medicaid, they leave. Oh, I have other choices. I can have my baby at Cedars now. Bye. And a survey done at the time I came by Blue Shield showed that among low-income Californians, 67% of those with no choice said that they wanted to change their current provider. So 2/3 of people are saying, when I have my choice, I'm leaving. I'm leaving the public. They weren't just talking about us, but surely we were among the public providers.
2/3 of USC employers may say the same thing.
Could be true. So that's the challenge. And just to say a little bit more about why that's an important challenge. Health reform and what Obama got passed, in my opinion, is a really good thing. But it does not include undocumented people. There are 1 million undocumented people in Los Angeles. If this is relevant, because if what you imagine is everybody has coverage, so nobody is left out, then you could argue if the public sector doesn't survive, okay, maybe the public sector shouldn't survive, right? If this public sector cannot deliver quality care and other people can deliver quality care at the same or lower cost, so be it. What's the harm? Well, the harm is, in this county, who's going to take care of all the people who are left out, right? If all of the paying people go somewhere else, how do you sustain the system for those people who have no place else to go? And keep in mind that hospitals have huge fixed expenses. So a place like LAC USC, if I had half the beds filled, I wouldn't have half the expense. I'd probably have about 80% of the expense. So some of my expenses are variable, things like nurse staffing, but a lot of my expenses keep going: equipment, utilities, medical staff, emergency department, ORs, whether I'm 100% full or 60% full. So what did we do? We set to say what I believe, and I'm a public sector guy. I believe that the public sector can be as good as the private sector. We have different pluses, we have different minuses, but overall I believe we can deliver high quality care, but we have to set that as a goal, right? We can't just say, like the old Lily Tomlin, we're the phone company, we don't care, we don't have to, right? If that's your view, right, you're not going to be a high quality provider. You have to decide that your future is necessary to be, you have to deliver high quality care or you'll have no future. So we enrolled a large number of people into the bridge to Medicaid so that they would get Medicaid on the first day. We started impaneling people, meaning that people would see the same providers over and over again, which in LA was an unknown thing in the public sector. If you came 1 week, you saw Dr. A. You came back 4 weeks later, you saw Dr. B. And everybody accepted that. There was no, Dr. B is your doctor, and she will see you, from now on whenever you go, right? Well, what is it that builds loyalty? If you do surveys of any population, including of USC employees, and you ask them about their insurance plans, what's important to them, the number one thing people consistently say is my relationship with my doctor. That is the number one thing. Of interest, number two is parking. I think it's really interesting. People want to see their doctor, and they want to be able to park conveniently. They don't want to, have to drive round and round looking for a parking space. We're successfully implementing an electronic health record and a specialty referral system, improving the patient experience. One of the big problems was unacceptably long wait times for specialty care, and we fixed that by creating e-consults, which enable a primary care doctor like me to send a consultation to a specialist and then get a response. So no longer do I schedule an appointment. And one of the things that has made this work so well is often a person doesn't actually need an appointment. They need advice. So I might have a patient with bad heart disease, and what I need to know is what's the next medicine to try. In the old days, on our system, that would mean having to schedule a cardiology appointment. Now I can send a consult to a real cardiologist. He or she can see the EKG, can see the echocardiogram, can see the medicines I've already tried, and make a recommendation. And it's done a huge amount to decrease our wait times. And I'll skip this. And then one more example, very similar. We had a huge wait time for eye exams. So we instituted these cameras that people can do in their office to take a picture of somebody's retina. And it turns out this is a huge issue in Los Angeles because we have an epidemic of diabetes. And all of the diabetics are supposed to have their eyes examined yearly, but we don't have enough ophthalmologists to do that, even if everybody were willing to go. But by instituting these cameras, which we can do, I could teach any of you in about 20 minutes how to take a picture of somebody's retina. Very simple camera technology. Then the images are read. And then the important part, they're only read as in normal or need to have a referral. And 66% are read as normal, which is a huge victory because it means 66% of the people don't need the visit. We're done. So I was able to go from a system where I couldn't have enough eye appointments to making eye appointments unnecessary for 2/3 of the people, better for them, better for the system, and now I have enough ophthalmologists to see the people who have retinal disease. And there are many more type things. I just wanted to bring this as an example. I always end, these are my kids, both of whom I adopted from an orphanage in Vietnam, as a way of saying, in life, there are lots of ways to make a difference, and it's not just our work lives where we make a difference. And I'm a big believer that you make a difference when you're a good parent, when you're a good son, when you're a good daughter, when you're a good friend, when you help out other people, right? But that the goal of life, especially for people like you, who are privileged by being smart and getting great education and having your lives together, then the goal is, well, how do we make a difference for people whose lives are not so together? And what's our common responsibility to everybody else as a way of appreciating the luck we've had to land where we have, in your case, in this great school, and in my case, to have what luck I have to have such an interesting career and where I get to make a difference. Important to me to always keep in mind that doing my best to try to make that difference. So I think we have, I wasn't watching a clock. What time is it, Raphael? How we do? 2:55, good, because I'd be more interested, there are lots of other things to talk about, more interesting for people to ask questions, or they don't have to be questions, they can be your own views of these things, or suggestions, or what you know about the system.
Thank you.
Thank you. I appreciate that. Thank you. All right, you're going to lead us off?
The downside potentially from DHS of the Affordable Care Act, have you seen people, obviously you've got more people potentially coming in, other people got more options and went elsewhere, have you seen that at all in your data?
So far what the data show is that we're retaining our population. But I don't believe that if we hadn't done what we did, that would be true. So in other words, if we hadn't impaneled people, I believe we would have lost them. The game, though, is not over. And the reason it's not over is that initially, the way we had done a very smart thing. We had enrolled all these people into a precursor program. So when they came time for Medicaid, they naturally rolled into us because the state used an algorithm that was based on where you had last received care. So when they couldn't go anywhere, we made a big effort to get them to us. Now, when the algorithm gets turned on last January, they all roll to us because what the computer file shows is that their last provider was us. It takes some time for people to figure out exactly what their choices are and to compare their experiences with those of their friends. So we haven't had the drop off, but I'm still conscious that we could seep out if people feel that, gee, I could get that done faster, somewhere else. So that's why I spend a lot of time on, things as basic as the phone system. To me, that's like a high, that's a high priority issue. Does someone answer the phone when you call? And when I got to LA, I'm a very sort of hands-on person. That's the only way I can figure out what works or not. So I go look on the web. We'll look up Los Angeles Department of Health Services. So I look on the web, and what I try to figure out, okay, I'm a patient, I want to go for services. What do I do? So, it's very convoluted, hard to figure out. Eventually, I find some phone numbers that are on the web. So I say to one of my new staff, I'd like you to figure out how to make the website more friendly. He says, he's really a good staff member. He says, I'm going to do that. He comes back the next day and says, well, worse than you thought. You know those phone numbers? I said, yeah, they're the only way I could figure out how you would get into the system. He said, they're all disconnected. Imagine the message there, right? After struggling with the website to see how, find it, because it's not like they put it right at the top, call, right? You had to go to multiple screens to try to figure out. It was clearly designed by someone who didn't want you to call, right? But when I finally found the numbers, disconnected. So, if you can't figure out who to call, right? Big problem. Please.
People leave the DHS. What are their options, and how does quality of care at DHS compare to those options?
So in LA, there are options of every type. So there are small practices that they're in the industry referred to as onesie twosies. One doctor, two doctors in an office. There are federally qualified health centers. Say St. John's, Saban, Venice. There are some of the hospitals have outpatient clinics that take care of people with Medicaid, not all, so not so much. Well, USC, for example, at the university campus, I don't think they have much primary care. But other hospitals like White Memorial do. So there are a variety of other choices that people could have. But it is true, people tend, at least initially, to go where they've gone. And it's only if what they hear, what would kill me is if people got experiences way better. I think what most people would say on the quality issues is DHS probably, by most standards, provides higher quality medical care by most criteria, which is to say, we have more board-certified physicians than most places do. We have every group uses nurse practitioners and other mid-levels, such as physician assistants and doctors, but we tend to be more doctors, fewer mid-levels, and many of the other providers, more mid-levels, fewer doctors. So we have very strong academic affiliations with USC and UCLA, and in general, academic medical centers provide better care. The problem we've had is that you can't get in. You can't figure out how to get in. The phones, the phone number doesn't work. There's no, you get in and they say there are no appointments. They treat you rudely. So the issue historically of the county has been that once you got in, you got really good medical care. So my job has been, which in some way is an easy job, and I think has been mostly successful. Gee, if you can get the medical care right, which is the hard part, surely you can get the customer service right. Right? That's not that hard, right? Nordstrom's knows how to do it, right? If Nordstrom's can do it, it's the same principles. It is really not very hard. I mean, patients are not so demanding of, fancy lighting and fancy carpet, but they do know whether or not the people care about them or don't care about them. And if nobody says hello and nobody says welcome and people make you feel like they wish you weren't there, you're going to look for a different place.
So I was very surprised to see these innovations with trying to reduce the shortage of specialty care. And one of the things that have been talked about a lot is the shortage of primary care physicians, and in particular with Medicaid, or sort of the poorer population. And that's part of the problem with what happens when you have universal coverage, is you have more people who want care now but not enough physicians to provide it. And so one of the solutions is to pay physicians more to see this particular type of population. Do you have a sense of how California either structures its Medicaid payments, or why they change, or whether there's any discussion over changing how we pay physicians to ensure that care?
Sure. Well, it is as you allude to, it's a complicated issue. So let's, just to be provocative, you want more primary care physicians? Pay primary care physicians what you pay anesthesiologists, and pay anesthesiologists what you pay primary care physicians, and see what happens to physician supply for primary care and anesthesiology. And I use that example deliberately because while there are disparities all over, so I'm a primary care trained physician. A close friend of mine who trained at the same time, she's a neurosurgeon. I understand why she should earn a great deal more than I earn. Right? I trained 3 years, she trained 9 years. A lot of the time I spend in the office, talking to people. She does this microsurgery with these procedures that last like 11 hours, where she's picking the tumor off people's spinal cord, right? She should earn more. That's a really hard job for which she trained and gave up income. Right, I was working and getting a living for 6 years, during which she was still in school. Anesthesiology is about the same length of the training as I do. Right, same with some of the other radiology, dermatology, emergency. Right? We've just decided that because of our love of specialty care or some of the dynamics in professional medicine, to pay people more for these areas. So if it's going to change, there does need to be some differences in what people overall earn. Nobody is against spending more money on primary care doctors, except that everybody wants healthcare to cost less. And healthcare, if you look at the GNP and what we get for it in this country, it should cost less. We're certainly not getting the outcomes that Western Europe gets with lower cost. Western Europe, by the way, the biggest difference between doctors in Western Europe and us is, in Western Europe it's 2/3 primary care, 1/3 specialty care, and in the US it's 2/3 specialists, 1/3 primary care. It's probably is why we spend more and get worse outcomes. So whether there is movement to increase primary care specialist salaries, but a lot of resistance to lowering specialty care salaries. And it's unclear how ultimately you make the money work. So a lot of the effort is going right now to the question of, can people other than doctors do primary care? And the answer of nurse practitioner, physician assistant is not such a satisfying answer because the price differential is not so great. A nurse practitioner might earn 110, a starting primary care doctor might earn 160. That's not a huge difference compared to, say, an anesthesiologist who's earning 450 or 500,000. So a lot of the movement is around, can other people do some of the work of primary care? And I think they can. Can you health coaches, right? Case managers. Certainly a lot of what any primary care doctor does is other than treat and diagnose illness. So that's a lot of work in that area. Go ahead.
I think that I was very inspired by the way that you presented these laws that are barriers to actually getting better performing health systems. And one of them that I struggle with right now are laws that prevent efficient research use of data.
Mm-hmm.
And I'm wondering if you could tell a story like this that says, okay, like we started in 2015 and it cost USC $120,000 to broker a governance agreement between CHLA, KEC, and DHS to try to get efficient research use of data. And that is based on trying to work around some legal systems that allow research use of data to be subject to a complete different structure than quality improvement and public health. And there's people in this room that could get putting their brains on that problem of better use of the data in these health systems to deliver value-based care, or have a barrier to accessing that. How would you tell that story for making it much more efficient?
Well, so it's a great question. Try to think of who's in favor, who's against. So, and what are the banners? I'm a big believer in banners. Banners are how you package the thing that you're doing so that people want to follow you. And that's why I think of it as a banner, right? Because it's the thing that's in front. And what you're trying to imagine is, and you might, while I'm talking, think about what you think the right banner is. But that'd be one of the first things I'd be thinking about is, what does that banner say? And I will tell you that the first thing you have to figure your way around is that, unfortunately, the other side has won this argument, and their banner is confidentiality. Who's against that? See, that's a very good banner for all of these dumb laws that really don't protect anybody. And everybody knows everything about us anyway, right? So, but if the people you're working against are successful, and they have been, and they've branded this issue as confidentiality. And if a lawmaker is looking at what you're trying to do, and someone over here is putting in his or her face the big sign confidentiality, they're going to be on that side because nobody's against confidentiality, nor are you. But so, what I would be thinking about is, okay, well, what would be my banner on the other side? And who would I get who would be willing to stand with me? So even on the cost, my first questions would be, okay, well, who's paying that money? And are the people who are paying that money, are they powerful people? Does the average elected official care about that constituency? Who cares about that constituency? What influence does that? So every public policy thing that I've ever done involves empowering your friends and neutralizing your enemies, right? And you can play that on the very local level, which is where a particular, let's say, political leader or community leader is against something that I'm doing. Maybe I can't easily change their mind, but maybe I know somebody who can change their mind, right? So maybe I can figure out who is a friend of the person who's against me and get them to change their mind. Or maybe when I'm most successful, I'll reframe it so they think that they do support it, right? So I don't know enough about your issue, but I would say it sounds like a great issue to work on. It would help certainly if people could see, and I think this is a little bit of the black box of big data, is what they're going to get out of it. It may be another challenge you have, is that outside of the academic community, people are not sufficiently convinced of the value of using these data sets to answer questions. So they don't see it. They're more thinking about, like here, there's a serious movement, if you're talking about banners. It's very likely that Congress is going to pass a right to unapproved treatment. Why? Great banner. Right, so do you know anything about the right to unapproved treatment? That's basically whereby, a company is developing a drug. It isn't yet to market, but it's known about in the research community. Someone has X awful disease. They're going to die anyway. Family learns company X is producing this drug, but the drug is not FDA approved. So politicians are very fast to want to line up for that. Why? Because it sort of sounds right? This person's going to die. What would be the possible harm of giving them that drug? That's a good banner. Whether it's good policy or not, I'm not so sure, but it's a good banner. This problem needs a better banner.
Could you speak briefly on DHS's strategies for addressing the homeless population, specifically any preliminary results from the Housing for Health program?
Well, I'll start, and thanks for the plug, by saying that from my point of view, homelessness is a completely curable condition. And I distinguish that from many things people have that I take care of. People who have awful cancer, can't do much about it. People who have end-stage heart disease, can't do much about it. Substance abuse. Sometimes, as you know from the stories that hit the newspaper about famous celebrities, the best of treatment, people continue to use. Homelessness, I can cure that. You can cure that. Our programs cure that, right? We have, in terms of outcome data, we have for the Housing for Health program, we have 90% retention rates at 1 year of people who are put directly from the street or the hospital into housing. We've completely blown the old paradigm up. That could have been a different example, and it's a different kind of example. It's an example of where a smarter idea is the solution. So when I was a resident, the way you dealt with people who were homeless was called the continuum of care, and the continuum of care said the first thing you do is you develop a relationship with a homeless person through an outreach worker. You try to get them to primary care. If necessary, you take the vans and you go around and find them. You encourage them to go into shelter. The shelter, they give information. They get referrals. First order of business is getting them to stop using. There was a belief you couldn't even evaluate people for mental illness until they were off alcohol, because alcohol can in fact cause depression. So you first needed to get them off alcohol, and then you needed to get them a mental health referral. And after all those things were done, then you'd do transitional housing, and if they didn't blow out of that, you'd look for permanent housing. And you can imagine nobody made it through the continuum. And everybody gets to talk about their great work taking care of homeless people. And meanwhile, everybody's still homeless. And we're providing all these services, and everybody's still homeless. So someone turned it on their head, and my housing guy, Mark Trotz, was one of the first under what's called the Housing First model, which is forget all that stuff. First, we house people. They're homeless. You want someone to stop being homeless? House them. So we house them. We house them right from the start. And then we work on those other problems. And as you might imagine, it's a lot easier to deal with somebody's mental illness when they're not living under the freeway, right? When they're not, in a situation where they're actually, in danger. Our costs are about to maintain somebody in supportive housing in terms of the real estate costs. Most of the units that we lease are about $1,200 a month for someone, of which we ask people to pay about $300 of their own income on average, because we ask people to pay a third, and most people in this situation are getting a $900 Social Security check. So our costs are about $900 a month. The rest of their health care costs we can generally get by billing Medicaid for visits that they get either at our clinics or for sending out nurses. The cost of a hospital day is about $3,000. So you don't have to save very many hospital days in order to make this work. And what the body of research shows, which is what you would all figure out anyway, is that whether it's cost saving, cost neutral, or just cost effective depends entirely on the population you choose. So if you only provide housing to people who are constantly in the hospital, it's money saving because a hospital day is so expensive. If you provide housing to homeless people who avoid hospitals, it's a very cost-effective thing to do in terms of the quality of life, but it's not cost-saving because they were avoiding the hospital, right? They were living under the freeway, right? So there's no cost saving. And the challenge, and this is, if you will, from the examples I gave, this is my modern day challenge. There is a specific part of the federal Medicaid code that says that Medicaid cannot pay for housing. And I'm currently trying to figure out, and if any of you want to work with us on smart ideas, I'm trying to figure out how to defeat that. I'm not easily deterred. There's my cynical defeat, which is I say, oh yes, that's not true. Medicaid does pay for housing. They're called nursing homes. So you're willing to pay for housing, federal government, as long as, you know, I institutionalize somebody, you know, at $250 a day, but you won't let me house. But that's not going to get me what I want. The closest I've seen to what I want is that Indiana has been successful at convincing Medicaid to pay them a premium, like you were talking about primary care premiums for paying more for primary care doctors, has agreed to pay a premium under Medicaid for every day the health plan keeps a homeless person housed. So they're not paying for the housing because the federal law prohibits Medicaid being spent on housing. But they were willing to go the step of paying an incentive to the plan for keeping them housed. So, you know, I'm trying to be on that cusp of figuring out, you know, okay, so I could work with that. That's the kind of thing that I like. You know, you just need a way around it because, again, you know, if we brought a bill to Congress, you know, could you find a sponsor? Yes. You could, I think, pretty easily get somebody to sponsor a bill lifting that exemption. Could you get it passed? Absolutely not. No way that in today's era they're going to lift that ban. So you got to find a different way.
Just a follow-up to that. So is DHS planning to maybe apply for a social impact bond or pay for success for things like that, or Medicaid kind of cover housing?
Sure. So social impact bonds are, a hot fashion at the moment. But my read is that the reason they're not more widely used is that it's not easy to find situations where you can guarantee the return of investment. And so just to say it another way, so health innovation bonds, the idea is like any other bond, they give you the money up front and you pay it back over time. So if you have an innovation that you believe or have more than believe, you have strong evidence to say will save you downstream cost, it makes sense. The problem is that even the housing, depending on who you do, again, it's much more cost effective than, say, doing CT scans on smokers to try to pick up early lung cancer. People have done that analysis, but that's not prohibited by Medicaid, and so Medicaid pays for that. But could I do a social impact bond for more housing for the homeless? Yes, but it would have to be restricted to only people who have a lot of days in the hospital. And my goal is to go way beyond that. What I want to do is I don't want to see, a lineup of wheelchairs on Skid Row. I think that's just unacceptable in a city and country as rich as this, to believe that the best we can do is a series of wheelchairs right down Skid Row. I mean, there has to be a better way. But to the extent that those people don't go in the hospital, I don't have a savings. So I can't use a social impact bond just because it's something good I want to do. You have to be able to pay the investors back. The place I believe there might be the social impact bond that I'm interested in looking at right now is some of the jail diversions. And the reason this social impact bond might work there is cost of incarceration is $130,000 a year, not counting any medical care. So just the custodial part of keeping somebody in jail is $130,000, and there's no federal or state reimbursement at a local level.
Bit of a digression, but I hear that number all the time. Why is it so high? It blows me away.
Deputies. It's a very high density of deputies. It's a 24-hour shift of well-paid people. I'm not saying they shouldn't be well-paid, but there are a lot of them, and they're well-paid, right? And I don't. Given how we've incarcerated people and the violence, I'm not sure I'd be advocating for fewer guards. I don't really know. But that's the expense you're paying for. Most of the expense is the guards. Because I know it does not include medical care. So if you could create a diversion program where you're diverting people out of jail, almost everything is going to be less expensive than $130,000 a year. Right, I mean, that's a job and a home, probably, and some support. So, but again, you can see how that's a limited, right, and of course, you're not going to get political support for diverting anybody with a violent anything, right, nor am I advocating for that. But, I mean, I would love to do more diversion for people with mental illness and substance abuse problems, right, with no history of violent crime. I'm just not, I understand why it's illegal to sell drugs, and I'm not sure that I disagree. On the other hand, it's hard for me to say exactly what I think the benefit. What is the society? Someone gets picked up for selling drugs, you put them in jail for 2 or 3 years. What have you accomplished? I mean,
we are actually doing exactly that. I work for the DPH, and we actually are applying for a social impact fund for the diversion program,
right.
Women's reentry court for nonviolent women offenders and substance abuse. But like you said, the impact is going to be quite small. And the social impact funds right now are limited to $2 million. And yeah, that's probably going to fund 50 people every year.
Right. Right. Well, good for you. You're doing what I believe in, which is you're making, right, the idea of making a difference is not, making a difference on necessarily the biggest thing in the world, right? It's making a difference. It's making a difference where you can make a difference. And sometimes the problem is very small, but it's a real person. And good for you for doing that. And maybe on the way, you'll either figure out other strategies that are better or more effective, or someone else will use the stuff you do, and that's how the world gets to be a better place.
I used to travel to Europe a lot, and it's pretty simple to say that what works over there, what you're talking about, seems to work pretty well. Healthcare is taken care of. Drugs are not such an issue. Violence is a little bit lower than here. Why is it so hard to get some of their solutions which work over here? I mean, I know you've been talking about it, but in a simple way, what would be an answer to that?
Well, I think clearly you're in the world of anthropology as to why Americans. I mean, and people have written books. Americans are, I think, characterized by a certain exceptionalism, a belief that America or the U.S. is different, and I don't think that the Western Europeans as much believe. I mean, the French, certainly don't see themselves as Italians or Germans, but somehow this sort of rugged individualist kind of thing just doesn't seem as much a part of their national characters as it is. The Americans are, very individualistic. They as a country, we seem to feel that we all get to decide ourselves what we want. And without going into it, I mean, the measles stuff is all about that of late, right? With people feeling a very hot debate. You know, do parents, you know, have the right to simply say that no, they don't want their children vaccinated, and they're not moved by the data that say, well, but measles vaccine doesn't cause autism. It doesn't move them. They are truly not convinced by that. And there are private schools in Los Angeles where, especially like the Waldorf schools, where like half the kids are unvaccinated. I mean, it's a perfect setup for an epidemic of measles. And yet there's great reluctance for saying, well, wait a minute, you don't just get to decide as an individual. Americans don't like to dictate. Okay, well, thank you so much.